So, welcome to week 8. And as I said, it's going to get very difficult. And there's a lot of demands, a lot of things you need to do. And then, oh my God, there's a HESI coming. So, I understand this is crunch time. Now, some of you are very close. What I suggest, please reach out to me. Let's do one-to-ones before the exam and one-to-ones before the HESI. I've got a lot of stuff for the HESIs to help you. I don't know, you probably have heard from other students. I have two 100 question Kahoots, which asks the same concepts over and over again. So that's like doing 200 NCLEX questions. But besides that, on Saturday before HESI week, I do a Q&A, I call it, and I go over the systems and the developmental stages, and I go over key concepts I know you'll see. I've had many students tell me during the HESI, they heard me talking and they could say, oh, I know the answer because of the question. And they're like, oh, that's what it is. If you study like I tell you to do, you will score over 900 on the HESI. And I do have quite a few 99.99s. So it is possible. And it's not that one who's an A all the time either. There are some students who, in the end, want it, go out, and they do very well. So I can help anybody get through, week 8 and get onward, all right? So week 8, there's quite a few assignments that are due. Number 1, that clinical pediatric assessment assignment. Remember, you must ask me whatever the diagnosis is. It does not have to be one on the list. It could be something that you know someone, or you, your kids, your cousin, neighbor, or you just want to know about a diagnosis. That could be a pediatric diagnosis. Just run it by me. I'm sure you could use it. And remember, that's going to make a better project for you because you're going to want to know what it is all about. And it usually is a better project for me to score because I love reading these. First of all, there's a paper, 250-word APA. Make sure you do those little citations throughout the paper, and there's references on it. You can describe the diagnosis, or you can describe a little diagnosis and tell me about maybe it was a clinical kid that you saw that you wanted to write about. You can describe them if you want, but just do 50 words. That's it. Then you're going to be doing the pediatric assessment form. A lot of it's going down and highlighting or circling where you are, positive bowel sounds, clear breath sounds, whatever. Just make sure that the assessment is what the diagnosis is. I'll give you an example. You're talking about asthma. Do not tell me you have clear lungs. Give me expiratory wheezing. Give me tachypnea. Give me retractions. Give me all that stuff, okay? Now, the third part is a teaching. Teach the child, teach a nurse, or teach a parent, teach all of them. What is it and how do you treat it? It could be how to give yourself, an inhaler. It could be taking all the antibiotics. It could be ADHD, how to be on a routine and maybe the treatment that's needed. Maybe it's something to do with chronic ear infections and how do you take care of those and what do you need to look for. I usually see PowerPoints, 5, 6 slides, all I need, okay? Brief, concise, that's all. Make sure there's references at the end, okay? Now, as you do a section, send it to me. I'll score it and I'll tell you, change this, and I'll give you really good examples on what to do. And I will send it back. Send it back, and I will give you a better grade for it. Okay. Now, don't wait till Saturday or Sunday if at all possible. Sunday later in the evening, there's no way I can go through 50 of them and get it done. So the earliest you get to me, it'll be better. And then you also have NCLEX questions and the pediatric assessment, the assignment exam. Remember, it's one time only. And I believe there's 70 some odd questions. And it does, again, it's starting to help you prepare for the HESI. So, yes.
Professor, sorry, I have a question. So on the assessment, so like let's say this is a live patient or is this
It could be
a
virtual, make one up.
okay. So
You
like
don't have to see in a patient. No.
okay, so is this so let's say I have a patient that's 18 years old. So are we doing like a Erickson or like one of those
At the end of it, there is a section, Erickson
yes.
Piaget.
Yes.
What should they be? What are they really? And
Mhm.
how would you treat that child? If they're
Depending
cognitively
on
delayed, they're not where
right.
they were. These are the things I'll do to make that child comfortable.
Okay.
And then there's two NANDAs after that.
And then what about things like, let's say, something is like, let's say, normal. Can we do like I know you said you don't want anything blank. Can we do like within normal limits or within
Now,
normal?
on the assessment sheet, you can, but there's
Okay.
areas on that talk about home environments and stuff like that. You know,
Mhm.
try to say there's no trip fall hazards, there's no allergens,
Okay. So
there's
something within
something,
that, just not like not applicable, or I know you don't want
right?
something like that.
I
Okay.
want you to think of things that maybe you'd look for,
Okay.
right?
Okay. Got
And
it.
it depends
Okay.
on the age, absolutely.
Okay. Thank you.
Oh, no, you're very welcome.
And did you say that the patient teaching that part needs to be in slideshows or
No, it could be a PowerPoint, it could
okay,
be a brochure, or a
okay,
picture board. Pictures
okay.
say a lot. Just make sure there's references. Now, this assignment has unlimited uploads. So upload it there. And then you also can look at the plagiar checker as we go to make sure it's not too much. Because there's 30%, that's about the limit. Unless the assessment form, that's always more because all the words of the assessment form are there. Any other questions? All right. And then, of course, don't forget your NCLEX questions this week, all right? They're always important. Next week is going to be our reviews. I do mine on Wednesday at 5. There is a Friday at 5:30, and there's two on Saturday at 10 a.m. and 4 p.m. So you have a weekend stuff too. And as always, remember, we do send the recordings. They'll be out to everybody. Again, anybody who wants to see me before the exam, just send me a message and I'll look at my schedule and we'll try to work out a place that we both can meet. What I always suggest is please look at least my recording first before you come, and then come and have questions or because I'll go over that PowerPoint quickly again, but you might say, wait, what does that mean? Or what is that word? Or what's this? And I can help you, okay? I know I've had people come every exam and they're doing very well. So it's your time. I'm willing to spend it. All you have to do is ask me. All right.
Now, are the review sessions next week
Next
or is
week.
it starting this week?
Nope, starting next week.
Okay,
And I will have that schedule out by Friday. I am
thank you.
personally making that study guide PowerPoint. It's a brand new one, and I am making sure the concepts that are on the exam or could be the HESI, they're there so that you've got a good information fountain for you to go back and fall on. Okay?
Perfect. Thank you.
Oh, you're welcome. It's what I do. I'm the one who does those things. I do quizzes, I do study guides, I just try and the Kahoots. I just try to make you be able to understand these concepts a little bit better. And I think with all the things that I do, I think if you look at them, you study them, and even the PowerPoints I've updated. This is an updated PowerPoint from last quarter. So there's always new stuff. So let's start with GU. Hope my voice keeps up with me tonight. So with genital urinary tract disorders, the number one urinary tract infections, we know that it's hard to figure out the infection on these children because of getting the specimen. We know with infants, the best way is through a straight calf, even though parents don't like it. Remember, infants are so small, immunosuppressed. We don't want to have to treat them with 2, 3, 4 antibiotics because we did a bag urine, because they don't work, because you're getting all of the skin contamination there. Another thing that's hard is uncircumcised boys, because if they don't pull down that foreskin and clean underneath, all that schmegma is like a petri dish. It grows bacteria, and that's what goes in and causes the infections. And the other thing we know is that sometimes kids don't like antibiotics. So all of a sudden, after 5 days, oh, the kid looks good. Oh, it's been a struggle to get them to take it. Okay, I've had enough. And we know that's when they're going to come back. They're not completely treated. Now, how do we know when you have a urinary tract? Well, of course, if the kid starts being incontinent, that urine smells horrible, or they start like holding themselves down there and wiggling and itching, and it's red, frequency, urgency, all of those things are signs and symptoms. Prevention, there are some things we can do, and we know the quicker we treat it, the better it is for the child. So knowing the symptoms helps. And then, of course, simple hygiene, washing hands, wiping from front to back, making sure children don't hold it, plenty of fluids. That's the biggest way to keep the urine flushing. And on the adolescent girls, we're not supposed to promote having sex or not, but if you see an adolescent who's having her third urinary tract infection, it could be due to being sexually active. Tell them to urinate as soon as possible after intercourse, and that does help decrease urinary tracts. Now, when we have an infection, we need to get that urine CNS. Now, we could do that straight calf, which we know is the most reliable and most accurate. And we'll do that on infants, usually 1 year and less. It's actually the best, and sometimes a little bit older, depending on the history of them. On a premature infant, we don't have small enough catheters, and it's very hard to see that anatomy. So we do a suprapubic aspiration, and it's a needle inserted right above the suprapubic bone, and it goes almost straight down. And it's with sterile gloves, clean it well with a needle, put it down, and you just need a half an ml. You don't need a lot. And that is an accurate specimen. And of course, usually premature infants are on some sedation. We'll make sure that they have something before it. If the kidneys is what's always getting infection, we'll do these percutaneous kidney taps, and that gets the urine right in the kidney. So again, it's getting the specimen from the source. We could do ultrasounds looking for structural. We'll do voiding cystourethropographies, which means we fill up that bladder. Usually we insert a catheter. We fill it up with dye, and we see if there's reflux going from the vesicle, which is the bladder, up into the ureters, or is it going back in the kidneys? And then it's a structural thing that we need to look at. Usually the intravenous pylographies, the IVPs, are kidney stones. And kidney stones, are just that painful, or we can do scans. Now, sometimes we have to do a renal biopsy for many things. We could be looking at the tissue, we could be looking at signs of infection, but we do the same procedure no matter what if we're going to go get a biopsy. Now, they will be NPO for, the older kids, 4 to 6 hours. The infants, maybe 2 hours before, because they don't do without sugar for long times. Whatever pre-medication, we'll set it up, we'll get it done, and of course, vital signs are done. Now, post-procedure, there is almost like a cardiac cath, the same things we do. It's going to be a pressure bandage, maybe a sandbag, and we're going to be looking at that dressing. We're going to be looking at the abdomen also. Is it oozing, the dressing oozing urine? Is it oozing blood? Or do we see the abdomen getting bigger, painful, reddened? And then, of course, we have put a needle in a kidney. We're going to be monitoring that output. We want to make sure the kidney's going. The other thing, just like cardiac cath, bed rest 24 hours. You know, post procedure, they have clotted off the area. It's not bleeding, it's not oozing. If they get up, you know, kids get up running around, clot will move, and then you're going to dislodge it and cause urine bleeding and some problems. And we know infants, they're so tiny. We got to do a little cut to look inside, and it's through the back is where the kidneys are. So again, that's an incision. Now, I mentioned about structural problems. And as I said, and this is in your book, this picture, your bladder is called a vesicle. All right. So vesicle ureteral. That means that from the bladder into the ureters, there's some obstruction. You know, hydronephrosis is water on the kidney. So knowing those names sometimes will answer questions. Now, there's a condition called nephrotic syndrome. I want you to know this is not renal failure. Your kidneys are working. They're working really good, but they're saying, you know, protein, oh, I don't like you. And it just removes all the protein in the body. So what do you see? Well, where is protein? Well, protein's intravascularly, right? We need protein, which is albumin, which is in the blood to give medications so that it's not too much medication being delivered. You need that albumin there. Well, it sucks it out and you urinate the protein out, the albumin. So intravascularly, it's become to the point where all of the fluid starts going extracellular. So you're going to have generalized edema on these children. They're going to look swollen. You're going to see proteinuria. There's no albumin or minimal in the blood, which would be hypoalbuminemia. And then you're going to have a lot of fats in your blood. It's just part of the whole thing. So protein, you're no good, goodbye, and it gets rid of it. So massive protein loss. And that looks like what you would see, foamy urine. I mean, that's probably a glass of beer there. It looks like one, but that's what it looks like. Now, how do you take care of nephrotic syndrome? Well, as I said, you're getting rid of protein. All of the fluids going extracellularly. Your generalized edema. Even your tongue and your cheeks are swollen. So you're going to lose your appetite because you keep biting on your cheeks and your tongue. So it hurts. So you don't want to eat. It's an immunosuppressive disease. So risk for infection. You're having too much fluid, right? Extracellular, generalized, salt restriction, fluid restriction. And with all of that, you're not going to feel like doing much. You know, it's going to be, you're going to be tired carrying around all this extra fluid in you. So you're going to have to pace yourself, these children. You know, they're not going to be able to go like they normally do. So family has the need to understand what these children are going through. So we need to get rid of all that protein going out. We need to make sure they don't get infections. I mean, simply hand washing is a big thing. And when you talk about any patient with problems with fluid balance, too much dehydration, generalized edema, nursing care, intake, output, daily weights. And these children will get steroids, is what we do when they're into the point where they're really swollen and it's uncontrollable. Now, we talked about strep causing rheumatic fever, right? Well, strep does something else. It also causes acute glomerulonephritis. So, two things with strep infections that are not completely treated. What is glomerulonephritis? What do you see? Well, they stop urinating. You don't urinate, the fluid goes extracellular, and you are edematous all over again. You're now have all this extra fluid, your blood pressure goes high. And this is one they say is periorbital edema. It seems to swell. I mean, they say nephrotic syndrome's more generalized, glomerulonephritis is periorbital. One of the problems with glomerulonephritis with hypertension, this child has a headache. You need to take it seriously. They most likely will need an antihypertensive medication during the stage, and this can be acute or chronic. Now, the strep infection made it happen now. It's an acute thing, but it could be forever, which means they'll be on antihypertensives forever. Because of all this extra pressure, because of this not urinating, when they urinate, it's going to be red brown in color. It's a hematuria, but it's reddish brownish. And we know there's going to be protein in there. There's a lot of similarities between your nephrotic syndrome and this. But what do? We can cure this. We cannot with nephrotic syndrome. They live with it forever. Glomerulonephritis, we're going to treat the strep infection. We're going to make sure that we monitor salt, INO, and we're going to be doing daily weights. Remember, always washing the hands. Most of them will be cured, but if after 1 year they're still with symptoms, they'll call this more of a chronic type of thing, which could be more lifelong. So the treatment is getting there as quick as possible and getting the treatment started, and those are better outcomes. So again, daily weights, INO. This one will be measuring the abdominal girth just because it's kidneys in the peritoneal sac. Okay. Again, low sodium, fluid restrictions, and they're also immunosuppressed during this time. So infections, be careful. Now, we covered Wilms tumor. It is a tumor. This is the nephroblastoma that was on the exam. And the biggest thing with this is all about don't palpate that abdomen. Also, we don't ever do biopsies on it because putting that hole to get it out will create a place where it can metastasize. And that's a nephroblastoma. Now, renal failure can be acute, which means something happened to cause it, or it could be chronic, could be due to a congenital abnormality. Now, an acute one is just all of a sudden the kidney stopped working. You know, one of the biggest reasons for acute renal failure is dehydration. Children need fluids. If you see a child that's dehydrated, our goal is to institute the best treatment as quick as possible, whether IV or PO. And we're going to go into dehydration in a little bit and talk about which would we do when. Chronic renal failure, you already have kidneys that don't work very well. And they call this uremia. Now, older kids can get dialysis. It works fine. Younger children cannot. And I'm going to go into that next. Now, chronic renal failure could be at birth that you have it. You know, hereditary. Your kidneys are not working right. You only have one kidney, many different things. And it could be a malformation of the way it was formed. It could, you know, eventually acute turn into chronic with some conditions called pyelonephritis or glomerulonephritis, right? We talked about that already, what happens. Also, what about lupus? Lupus attacks any organ. It can attack kidneys, causing chronic renal failure. And anaphylactic purpura, big anaphylactic, thing that goes on, it can damage and cause chronic renal failure to your kidneys. So our goal in renal failure, now you're talking some of these kids, 5, 6, 7 years old, that are taking hemodialysis 3, 4 times a week. So their life is 4 to 6 hours every day somewhere getting these done. So, nurses have to be inventive on how we take care of them. And I've seen some great things at the hospital where I actually was a clinical educator. And our floor was the GU floor, or the dialysis unit area. And I used to see some amazing things that these children and nurses did together. In fact, sometimes they'd even play instruments together and tape them for each other. I mean, just wonderful things. Anyway, our goal is to get the best renal function we can. We've been taught that erythropoietin is formed by the kidneys for red blood cells, right? It makes red blood cells. In kidney failure, it doesn't work. That means that production is decreased. Therefore, hemoglobin hematocrits can be low. These children, we will be giving them subcutaneous erythropoietin. Again, mimicking what the kidneys do for themselves. And, it does help decrease the amount of transfusion we have to give. Now, you heard me say that hemodialysis cannot be done on younger children. Well, at birth and the young children, we have kids born that don't have kidneys that are working. I mean, it's like prune gut is one of them, or prune belly is one of those syndromes. So we have to do something to get rid of all of that, stuff that the kidneys does, right? So we do something called peritoneal dialysis. They take the peritoneal cavity and use it as a filtration device. And they put a catheter inside there. And then we take a machine, and there's heated solution that the nephrologist orders, and we put them on cycles, usually 8 to 10 cycles, and we usually do it at night. Parents can do this at home. I saw one child for 2 years, the mother did it, never ever had an infection in the peritoneum, which was a testament to her and her diligence in sterility. But what they do is they heat the solution through a tube, put it inside the abdomen. Could be 100 mLs of fluid. They let it sit there or still for a time, 20 minutes, 30 minutes, and then they drain it. That's one cycle. They'll do 8 to 10. At the morning, when they're done, they will look at the fluid in the Foley bag, because usually that's where it goes to. And the difference from the amount of fluid we put in to what's in there is urinary output. And that's what we do. And this does not put turbulence in the head, because that hemodialysis pulls it out and pushes it in. Turbulence is high, and those vessels in the brains will blow, and you'll have all these interventricular hemorrhages, which can cause cognitive delays and epilepsy and cerebral palsy and a whole different things. So this is very safe. So one of the things about peritoneal dialysis is all you have as a kidney is your peritoneum. We will prevent infections at all costs. This is one that you will wear a mask and a gown and gloves and a cap and do the best sterile technique as you can, putting it on and taking it off. Now, how would you know if an infection was starting? Well, there'll be a change in that color of what's draining. You might see exudate or something in it. You might see a little tenderness or redness in the abdomen, but usually the color of it changes first. And as soon as you see that, that's when the doctor has to be called and antibiotics need to be started ASAP. And that will help keep that abdomen as a kidney. Because if this gets infected and we can't use it, what else is there? There isn't. So what best describes acute glomerulonephritis? Anybody? What's glomerulonephritis?
EST with renal vascular disorder.
It's from another strep infection, like rheumatic fever. So there's two things that a strep infection that's not treated can cause: rheumatic fever and acute glomerulonephritis. And again, we'll just treat the strep infection. Okay, GI. Now, there are a lot of things in GI that in the adult world never sees. So I'm going to go over those things that you need to know. So nutrition disorders is a common occurrence. It's due to many things. And remember what nutrition is good for: from birth, cognition, and growth, right? Not proper nutrition, child's not going to grow, and it's not going to be cognitively growth development where they should be. There are many reasons why there can be a delay. Could be something that the body metabolically doesn't tolerate, could be cancer, HIV, sickle cell, cystic fibrosis, or they're born with a low birth weight, so they can't get enough nutrition. Now, celiac disease is a thing in the small intestines where gluten, which starts and helps, um, it's a component of wheat, rye, barley, and oats. This is all your flours. This is all of your noodles, your breadings. So all of those things is gluten. And when you give them gluten, all of a sudden the celiac in there, there's no fat absorption, and fat is just dispersed. And you'll see this pale, bulky, the smelliest stools that you've ever smelled. So you're not getting fat, is the bottom line. So nutritionally, these children suffer. These children need a high protein, high carbohydrate diet, and low fat. If you give these children fat in their diet, their abdomen's going to be distended and they're going to be uncomfortable and they're going to have this stools that are bulky and malodorous more than usual. So, how do we treat them? We don't give them wheat, rye, barley, or oats. There are so many alternative flours today, as in there is rice flour, and rice is a great supplement. And there's so many more today. You go into a local grocery store and you'll see gluten free on everything today. 30 years ago, they didn't have it. These children can have their vegetables, their protein, they can have dairy. I mean, you have to be careful with the fats, but they can have dairies, cheeses. So there's a lot more they can have than not. No macaroni and cheese and chicken nuggets for this toddler, which is the diet, right? Now, food allergies are common. Remember, at 6 months, we give these children, they start food, and we wait every 4 to 7 days. And we wait so that we see if there's some sort of allergy. The allergy could be vomiting, diarrhea, abdominal pain, or it could be a rash like this little child here. So One of the things with food allergies, one of the big ones, is lactose intolerance. Remember, if they're lactose intolerant and can't have milk, these children are going to have problems with vitamin D and calcium deficiencies, and they should have some supplements. Now, GI has a whole bunch of things that can be a problem. You know, you don't eat, you're spitting up, you're not going to grow, right? You can have nausea, vomiting, you can have diarrhea, constipation. I mean, you're going to have abdominal pain, you can bleed. The liver has to do with the GI tract. So, jaundice, if it's not working or it's clogged, like with biliary atresia. And then there's syndromes like Pierre-Robin, DeGeorge, which has problems with dysphagia, this difficulty swallowing, which require speech therapy. And then, of course, fever. And why is fever there? Well, fever burns a lot of fluids. You don't have enough fluids, it's going to cause problems. So that's why that's there. Now, as I said, dehydration is not good with children. It's because fever, you've lost fluids, or your kidneys are urinating too much, you're vomiting, you're diarrheaing, or you're diabetic and go to ketoacidosis. And then, of course, burns. All of that fluid is off when your skin is burned. Now, I love the pictures of these two babies. I think visually they describe dehydration so well. So, what do I see? I see a very pale child. I see very sunken fontanelles, right? That's just by looking. Then, if I go further, they're going to have an elevated heart rate, a low blood pressure, prolonged capillary refill, urinary output's going to be decreased. And what's the saddest thing to see is a child, especially your younger infants, they cry, there's no tears, and their eyes are sunken into their head. And it's so something you see, you will know. Also, skin tenting. And yes, infants do get, and children do get skin tenting when they're severely dehydrated. So it depends on if we're going to give oral or are we going to give IV replacement. Now, let's see, a child looks like these two here. They're going to get an IV. They just look severely dehydrated. So we'll start the IV and we'll make sure that we draw a basic metabolic profile. I want to know the glucose and I want to know what their electrolytes are so that I know where I'm starting at. Remember when we start an IV that even after we give a bolus of fluid, we'll give a bolus of fluid, never have glucose in it. You do not bolus glucose. Also, you never bolus a fluid with potassium chloride in it, okay? Also, after we give that 0.9 normal saline bolus of fluid and the kid's heart rate's down, the kid's, getting perkier, you will not add potassium to IV fluids, even maintenance, until they void or until you have a potassium level. And if they're vomiting, of course, you're going to give that antidiuretic for sure. Now, let's say this kid was admitted really like looking like one of these children, these infants right here. How do we know it's working? Well, probably we could tell just by looking, the kid's more active, color looks better. But the definitive thing is look at the weight on admission and now look at the weight that you last took. I can tell you most likely they've gained weight with the extra fluid that they've gotten. So that's one of the telltale signs. Now, output and input, what do we look at? Well, intake output, urine, stools, vomiting. Now, I have never measured sweat before. I've never had an infant a lot, but let's say we did. You can like take a chalk or a big diaper, weigh it, put it underneath the infant, And when it's damp, take it out, weigh it again, and that's going to be an output. You can if you need to. Of course, vital signs are going to be showing it. Skin turgor, mucous membranes, body weight. They're losing weight, they're still losing fluid, they're gaining weight. Okay, we're catching up. And that fontanelle in an infant is that sign. They come in with a sunken fontanelle and now it's flatting. We know fluid is getting better. And because you're not perfusing in the brain, you're going to have sensory alterations. It's hard to tell in the younger infants, but older kids you can tell. Now, there's all sorts of diarrhea. Now, how do we treat diarrhea? Well, if they're not vomiting, there's no reason why you do not give oral rehydration. Pedialyte, Powerade, Gatorade, doesn't matter. It's an oral solution that we give. If they're semi-comatose or very groggy, that's when you would start an IV, but usually they don't need it. And we'll give them the fluids, put them on a maintenance, and we'll reintroduce that diet. If you do not feed a child with diarrhea, their stool is going to be continued in diarrhea because there's nothing to form it up. In the hospital, they usually tell you, give them a lactobacillus, and that actually firms up the stool. Constipation happens in children. Many times, during that potty training time and they're potty trained and now they're, constipating, usually there's an underlying reason, and a lot of it could be emotional. It could be that they're not happy at home, or maybe they lost their dog. I mean, all of those things, you think it's not that much. Young children take things very close to heart, and some of them will show that by being constipated. I have seen 3-year-olds go 7 days, 10 days without moving their bowels. And you take an x-ray and the whole colon is full of stool. Now, we do not believe in giving enemas and laxatives just normally. We would maybe give it to that 7 to 10 days to get them going, but no, after that, it's diet. Now, we talked about last week about hypothyroidism, and we talked about one of the symptoms of congenital was no stool at birth, right? And I told you there was other stuff. Well, cystic fibrosis is one of them, hypothyroidism. And then, of course, any, thing like atresia stenosis is an opening that's not good, absolutely can cause it. But there's something called Hirschsprung's. And in a couple slides, I'm going to show you what that is. I mean, this is a picture of what you normally see at birth. This is the stool. It's black, green, and it's sticky and gooey. That's normal. Many infants come out passing their stool right at birth. So not having one for 24 to 36 hours, it will be investigated. Now, during infancy, usually you will see breastfed infants. They move their bowels really well, not a problem. In fact, usually breastfed have a lot of stools. The more infant that's more apt to be constipated is the one that's on formula. And it's just because the formula, I guess, is thicker. I'm not sure. But it's something that we're not going to give laxatives or enemas. The doctor might say, oh, give an ounce of prune juice or apple juice and do it very holistically, getting them moving it. Sometimes we'll say, take a rectal temperature, and that stimulates the bowel to have a bowel movement. An older child, we could give whole grains. And what about black beans? I put this in there because I'm from Miami. My children are half Cuban, and black beans is just a mainstay, but it is fiber. It helps them move. Now, enterobiasis, another name is pinworms. These are young children that like to go outside, play in the dirt, and then they have their fingers in their mouth, right? What do kids do? Everything in their mouth. There's always a finger in the mouth. And the symptoms are anal itching and scratching at night. And because they're scratching and itching, they're not sleeping well. So, how do we get a worm? How do we get that, confirm that diagnosis? Well, at night, you use a flashlight and you check the anal area and you take a piece of scotch tape, put it on the anal area, and that's the size. They're tiny and even smaller than that. And then you would take the little scotch tape, put it in a baggie and seal it, or a jar and seal it, something. Get it to the doctor for confirmation. Now, if a child has pinworm, the whole family should be checked because it is passed along. And one of the ways to treat it is keeping those nails short. Dirt can't go under the nails because there are always nails in the mouth. Children do get ulcers. We treat it just like adults. We might give, now the book is still on ranitidine, Zantac, but Pepcid today is the anti um, gas of today. And all it does, it decreases the amount of gastric acid, which burns the stomach lining. It decreases it, so it will help it. And of course, diet always. I've never seen a piece of a stomach removed as in a gastrectomy on children. Usually it's diet and medication, and they do well. And of course, it could be due to psychosocial again. Liver problems, children do have it. There's many reasons why. It could be due to virus, autoimmune, metabolic, something is going on. It could be biliary atresia. The whole duct is blocked and bile can't get into the common bile duct into the duodenum for digestion of food. And then you turn yellow, right? Could be that. There's many things. But any type of liver inflammation, we're going to treat it with mostly diet, to try to, again, it's all about nutrition, high calorie, high protein, and of course, low fat. Again, they're not absorbing fat. They're not absorbing fat. Their stools are going to be pale also. And of course, their skin, their sclera can turn yellow. And if you give fat to these children again, what happens? Abdominal bloating and pain and gas, and it hurts. Now, this is the other thing that causes constipation in the newborn that needs investigation. So we do a sweat test for CF. We do thyroid, levels to make sure it's not the thyroid. And then we're going to do an abdominal x-ray. And what we're looking for is a descending colon large. And sometimes you can feel it. You don't even have to x-ray it. And what the problem is, there's no nerves in an area of colon. So there's no peristalsis, nothing to move the stool down, and it gets enlarged. There's no nerves, it doesn't hurt, but you'll see the abdomen getting bigger. It is called a congenital aganglionic, that means without nerves, megacolon. You're going to see, as it goes on, that abdominal distension. And then sometimes that little tiny little rectum, do you see that little tiny tube there? Sometimes a little bit squeezes out. It's like a frosting being squeezed out of one of those things to do a cake. Tiny little ribbon stool. You might see that with Hirschsprung's. So if it's not diagnosed at birth, that means constipation wasn't that severe. We didn't see it, it got skipped. And now we're having more and more constipation and we're looking at it. These things we're going to be, again, doing the x-ray looking. They'll do a rectal biopsy. and they'll look to see if there's any nerves in that area. And they might do a barium enema to look at, were the whole things, yes or no, maybe, maybe not. And they do two things. The most common is a two-part surgery. And what they do is that area of colon that is not working, has no nerves, there's no use for it, they cut it out. And then they pull the good place up and they put a colostomy. Usually, that colostomy is there and closed within the first year of life. Once we are done with surgery on these children, there's a couple things that we need to know. We're not going to ever do rectal temps on these children. Leave the rectum alone. And number two is we need to have that bowel resting for 2 to 3 days post-operatively, nothing by mouth. Many times there's an NG tube down. We want to keep it very, very empty. Now, another thing that might be done is least popular. It's called a pull-through procedure, where they cut out the bad piece, but they're able to attach the good back to the rectum. So there's never a colostomy. So one or the other, they've got to get rid of that piece of intestine. Now, appendicitis. Appendicitis, very common in kids. And it's right lower quadrant pain, McBurney point, rebound tenderness, all of those things that you know as symptoms. These children walking into the ER, I mean, you can actually see them if they're walking. They're bent over, their right hand is in their right lower quadrant, and they're limping on the right leg. And you're like, ooh, and they're in pain, you could tell. You're like, okay, you're probably an appendix. So immediately you'll tell them, please don't give him anything more to eat or drink. They'll do an ultrasound, they'll confirm it, they'll start an IV, and they will give pre-operative antibiotics just to be sure, because these things can rupture. And they'll also give this child, if they're on any medications they need to have, they'll give it to them. Now, many times the appendix rupture. Now, the kid all of a sudden has no pain, and the kid's like, oh, I don't hurt anymore. I'm okay. No, they're not. They're to the point where now they're going to be peritonitis and have a really raging infection in their peritoneal sac, and it's painful after it gets going. So, post-operatively, they've done their surgery, they've cleaned it out, washed it out, done the best they can. But remember, all of that peritoneal area is completely been smothered in all of this infection. They'll be NPO for several days. So they'll get IV fluids. They'll be given IV antibiotics because that's an infection that's in their abdomen. And we'll be monitoring for their electrolytes because they have an NG tube in now. And because we're giving them fluids, we want to make sure they're getting what they want. And we'll be monitoring their white blood count. Is their white blood count coming down? Is the infection getting better? This NG tube is in there for a reason. Kids don't really like it, but they didn't have to get it put in awake. So they wake up with this thing there, and we need to tell them that is sucking out all the bad stuff inside their tummies. And what it does, it stops all the gastric juices from going down into the intestines. And the intestines are all angry. They're red. They don't feel good. They've had all of this infection bathed all over them, and they're, not happy. So if we decrease the amount of gastric acid and any secretions going through, these kids do better and the intestines are better. Now, we'll also be looking at their wound. Yes, it's the suture line should be good, but remember, that was all infected area that we're closing up. I have seen appendix incisions open up and dehisce because of the infection inside. So we need to watch it. Just like adults, we need to give them pain medicine. We need them up out of bed. We need to ambulate them. They need to cough. They need to deep breathe. They need to sit in the chair. Again, all of those post-operative complications. Now, good pulmonary care. You can be very creative as a pediatric nurse. They can blow bubbles or get them a pinwheel, let them blow it. I've actually had a young adolescent who actually had a trach transplant. I used to give her a straw at night and we put up a little target and we would do spitting out of the straw trying to hit the target and we'd see who'd win. Just think about how much deep breathing and what I did. And the lungs on that girl were great. I mean, a younger kid, you can't do that. They'll choke on the little pieces that have to spit out. But be creative, blow bubbles, a pinwheel is great. Now, something that you probably never heard of is an omphalocele. It's when the belly button doesn't close, it's open, and the insides are out. And it's usually in a sac. When these children come to you, make sure that they have a moist, sterile dressing on it. And watching out for infection is the thing. Now, their insides are out. We need to keep them warm, so they need to be under a warmer. We never turn them on their bellies. They're never swaddled up in blankets. We need them on their back so that this can be slowly by gravity will fall back into their abdomen. The surgeon comes every day and pushes a little bit more back in until they can close it. Now, everything works, it's just on the outside. We will be giving antibiotics. We're preventing infection here. Their insides are on the outside of the world, so chances of infection are big, and they are NPO. Many times they have an NG tube again to keep their stomach empty, but I've seen quite a few of these, believe it or not. Now, an intussusception is a telescoping of the intestines. Small intestines, large intestines, any intestines. They suck up into each other. And when it sucks up, sometimes there's a discharge of a little bit of mucus and we call it like jelly, currant jelly, and a little mucusy looking stuff, a little blood that could be in the diaper or in their underwear. It's one of the things I look for. But what you'll see with a child with this, 3 months to 3 years. The youngest one I've ever seen, and only one, was a 5-month-old. Usually they're 2, 3 years old. And these children are crying. They're not consolable. Their legs are just going, and their abdomens are tight. And it's a sudden onset of pain. And then all of a sudden they stop, which means it came out. And then all of a sudden it goes in, and now again, they're screaming. Those are typical signs of intussusception. Now, if we can get that intussusception, which is still inside, we'll do the ultrasound and look at it. Many of times, spontaneously, it comes out. We send them home, high fiber diet, telling them to come back if the pain starts again. Many times I've seen where there was so much swelling when those intestines went in there, it couldn't come out. So the radiologist under fluoroscopy does either an air enema or a barium enema, and that pushes that intestines back. When they do the air enema, it's like a blood pressure cuff when they pump it up, and all of a sudden it pops, and then the kid's fine. Now, I've seen only one, and I've seen about 10 of these, one that needed to go to surgery and have it removed surgically as a colectomy. But many times you send them home with a high fiber diet and they do well. Now, Meckel diverticulum is a duct, this piece of tissue, I call it, in the small intestines. And this little tab that comes out inside has a big blood vessel in it, highly vascular. Something goes through and it tears. And now you are seeing bright red blood. painless, minimal tenderness maybe around the abdomen. And with that painless rectal bleeding, they'll go and they'll do this radionuclide study where they're figuring it out, and they'll do surgery and they'll go and remove that little diverticuli, and they do well with great recovery. IBS, I mean, some of you might have IBS, ulcerative colitis, Crohn's disease. It's mouth to anus. It's the intestines that is having problems where it's inflamed, and diets that's that they need to follow. It is an immunosuppressed disease. Some even required biologic infusions like ulcerative colitis to keep it. Mostly we treat it with diet if diet works. We know with ulcerative colitis, you're going to see profuse diarrhea when the intestines are not feeling well. Many times, if it's not just diet, they treat this with some steroids to stop that inflammation. Sometimes they need to go in and remove sections of the diseased bowel. And again, of course, it's always nutrition. Now, short bowel syndrome is hard to understand. So let me give you a story about a triplet called Jessica. Jessica was a hypoplastic left heart child who came in for her second stage surgery at 8 months old. And we had a little ND tube, so the nasal tube for feeding went in her duodenum, and we had it like at 3 or 4 mLs per hour, like hardly anything. And all of a sudden her belly got big. And they're like, is it not? They weren't sure. Finally, they're like, okay, let's take her to surgery. They had to remove 58 centimeters of her small intestines. What does the small intestines do? It absorbs all your nutrients, right? So this poor child had very little area to absorb nutrients. So this child had to go home with a Broviac at central line. She got hyperalimentation, lipids at night. She had a gastrostomy tube put in, and she had tube feedings during the day, and they gave her as much nutrition as they possibly could. I actually met her again when she was 18. Actually, the last day that I was working in the hospital, her and the triplets came in. They had kept missing me for years. And mom knew me, and all the children knew who I was. And she was thinner, yes, but she was eating some by mouth. Yes, she had some cognitive delays because of multiple other stuff. But it was nice to see that at 18, that where she was in life, and to see the triplets with her. So again, it's nutrition, whichever way we could get it into her. Now we saw the omphalocele. It's the same thing, gastroschisis. It's the same sort of name there. And that thing that Jessica had that removed all of that intestines is called a necrotizing enterocolitis, or NEC for short. Her bowel died. So they removed that 58 centimeters of it, NEC. Now hernias can be anywhere. The belly button, the inguinals, it could be diaphragmatic. Diaphragmatic hernia is one of the sickest newborns that you'll have. Intestines are all up on the left side of the chest. There's no lung on the left side, and it's pushing over on the right. So this is an airway problem. So I've seen quite a few of those. Remember those little umbilical ones that you push your finger in and out and they soft squishy? Oh, I think they're fun to squish. If they get hard, red, painful, it could be incarcerated, strangulate, it's twisted, it's dying, it needs surgery right now. That's what that means. Anorectal malformations. Ever see an infant that was born without an anus? I never have. But there are some, they are born. This is why you do a rectal temperature at birth. You're told in maternity it's to get an accurate temperature, right? Well, is to check, do they have an anus in there? So an imperforated anus, there is no anus, so you can't do a rectal temp. What they do is, now there's nowhere for stool to go. So this child will have a colostomy. And they actually, through many stages, get that um, intestines down and they form an anus of some sort. So they do something to try to help. One of the things that physicians usually don't see, it's the nurses, is a fistula. Could be a fistula between the intestines and the bladder, could be the intestines and the uterus. You might see urine come out of the rectum. You might see stool coming out of, in the urine or the vagina. And it's you wiping those children who see it. And it's something that will have to be repaired, or again, infections. And children, they love to eat everything in their mouth, right? Some of the things, the most common that I've seen is Flintstones chewable vitamins. And as long as they don't have iron, they're actually not that bad. It's when they get to the Tylenol or the ibuprofen, or they're getting into grandma's medications, et cetera, that again, there's going to have to be more emergent treatment. And as I've always said, call poison control. As a triage nurse, that was my job. I called poison control and found out what we're supposed to do. One of the things we don't think about is in older buildings, back in the 40s, their paint was lead and children like to go up to the windows, right? And they bite on the windowsills and they get down to the lead paint. Again, remember, lead is dangerous. Now, vomiting is something that children do. It could be because they're overfed, it could be due to GERD, many different things. So if they're vomiting too much and they have signs of dehydration, we will put an IV in. If it's just one vomit, the kid looks great, they might give medication, wait a little bit, and then start slow oral. But usually vomiting, they're going to start an IV. Remember to get that basic metabolic profile. Start an IV with no dextrose and no potassium in it. And you will keep them NPO until you give them medicine, bolus is completed, and then slowly introduce. As I said, some vomiting could be reflux, GERD. GERD could be due to intolerance, could be overfed, could be the valve is weak, and they're always spitting up a little bit. I always ask a parent of a young infant that came into the ER, they're vomiting, describe it. Is it a dribble or is it forceful? Because the forceful one is something different. Now, what do we do for reflux? Well, in the infants, actually, we thicken their formula a little bit, usually with some rice cereal. And yes, even newborns. They don't get any nutritional value from it, but it keeps the formula in, so actually they gain calories. The older children, you're not going to see usually a lot of spit up. What you're going to see is them coughing. This is like mini aspirations. They're coughing, and you're going to feel pain in their abdomen and heartburn. And again, we can treat that with medications, or we might have to do a surgical thing. Now, this is a picture of a Nissan fundoplication. They take the stomach and pick it up over the esophagus so you can't vomit. And they use that. And that's the most radical of all, instead of diet and medications. But sometimes children just don't respond. Another thing, you will see a Nissan fundoplication with children or adults that need to have tube feedings, because you can give the tube feeding and now it's not going to go up the esophagus and they're not going to aspirate and vomit it. Now, as I said, there's that spit up, that's, GERD, that reflux, and then there's the across the room. And I'm talking about an infant, could be 3 weeks to 3 months. And if they're vomiting, you could point them across the room and they could hit the garbage can. I'm talking 10 feet straight ahead. It is that forceful. Why? Well, the sphincter, the pyloric sphincter, which is between the stomach and the small intestines, the duodenum, is hypertrophic, which means it's muscular, it's tight, there's no opening. Formula, milk can't go down, so the stomach fills up. And then all of a sudden, the stomach says, that's enough, and vomits with force that I said, point it towards the garbage can. It will hit the floor, splatter everywhere. It is quite impressive, the vomiting. Now, if a parent is telling me that it is forceful vomiting like that, I take my hand and put it right under the xiphoid process. And sometimes in the middle, a little bit to the right, there's this little hard olive size something. I call it a marble because it's about that size. And that's the pyloric sphincter. So what they have to do is diagnose it with an ultrasound. And if I know that they have a possibility of this, I will tell them, please do not feed your child anymore. They're just going to vomit again. Because again, every vomit could be an aspiration. We don't want to do that. So we will start an IV after the ultrasound. It's confirmed. We're going to start an IV, and they don't need antibiotics or anything like that. Just NPO and IV. Postoperatively, we'll start them with some clear liquids, and they usually go home in a day or two, and they do really well. Ever see a cleft lip? Cleft lips can be quite devastating to parents if they don't know. Be one side, two sides, or it could be the palate open underneath. And the thing with children and their lips, they needed to put around a bottle or a breast to suck to get their milk, right? So this is a nutritional issue. That lip we will close within 2 to 3 months. These are from your book, all the ways that it could be. Now, the palate underneath sometimes it's just a palate. I've seen that. I've seen one side or two sides. I've seen them both. They fix the outside first, 2 to 3 months, and then that palate usually between 6 to 12 months. If we don't fix it that soon, it's going to have a profound effect on their speech because they can't pronunciate their lips, their mouth. It doesn't do that pronunciation well. So they'll talk like this. You really can't understand them. So it's important that we do fix it. The big issue is feeding. Now, this is a bottle called a Haberman bottle. It was actually made by a parent. And that soft area, you turn the bottle over and the milk goes in it. And as they try to suck, you sort of, and it's really soft. And if you just slightly touch it, it will drip milk in the mouth. So the infant feels like they're sucking and swallowing, and it works well. Now, to breastfeed, you really have to just squeeze your breast in there. For having a parent, a mother who's going to breastfeed, it is quite a commitment because there's no suck. It's open. You can't get that suction. Another thing, esophageal atresia, tracheoesophageal fistula, is either not a connection or connections where they shouldn't. Esophageal atresia, without connection of the esophagus to the stomach. So there's just a tube from the mouth to the stomach, but it doesn't connect. Tracheoesophageal fistula is a connection between the trachea and the esophagus. So you feed a child anything, It goes down the esophagus, over through the fistula, into the lungs, aspiration pneumonia. And that's the big thing with this. How would you know the infant had TEF or esophageal atresia? How would you know? Well, at birth, they're going to have mucus. They're going to be coughing, gagging, sputtering, and even turning cyanotic. Many times right after birth, they give them a bottle of glucose water for their glucose could be low. When they drink it, they're going to be like aspirating, coughing, and choking and turning blue. And that would be the sign, oh, possibility. So what do we do for these children? Well, we got to keep the airway. So suction at bedside. Head of the bed should be elevated. Nothing by mouth. We will be giving them IV therapy and also antibiotics. And the reason why antibiotics is because they have mini aspirations no matter what you do. They can fix it, they can repair it. There's nothing wrong with these children. It's just that their connections aren't there. Cognitively, they're fine. So any questions? A lot of weird stuff, isn't there? Things that you like, oh, I've never heard of these things. And I've seen all of them except for no anus. That's the only thing I haven't seen. The rest I have. So who wants to win tonight on the Cahoots? Oh, McCormick is already going. Go ahead, William, get him for me. Sarah looks like he wants to do it too. Yeah? Okay. I'm with you. I have a couple of things in the Cahoots that aren't in the PowerPoints like normal. A couple little things just to bring them to your attention. And I'm going to get going because we need the time. So GIGU week 8. There's a lot of selectols here. All of the following are symptoms of dehydration in an infant. This is a huge concept. Dehydration, adults, children, don't matter. Huge, big concept. They're not going to have urine output or very decreased, and it's high heart rate, low blood pressure, poor capillary refill, decreased urinary output, skin tenting, weak lethargy, dry skin, etc., etc. A lot of stuff. Very good. What is the priority treatment for a child with dehydration due to profuse vomiting? When you're vomiting, what do? They're saying the kid's dehydrated. Profuse vomiting, dehydrated, IV fluids. You wouldn't give oral to this child. What is a treatment for an infant with diarrhea lasting for 4 days? Remember with diarrhea, if you don't feed these children, there's nothing to have stool, so it'll continue liquid. So we want to start those fluids and then slowly introduce the diet. What acid-base imbalance might you see with a child that's having profuse diarrhea? Well, there was 4 acid-base questions on a HESI a couple ago. So I teach you these acid bases because vomiting, diarrhea, hyperventilation were the big three ones I remember seeing. Oh, and DKA. When you have diarrhea, what's in it is the enzymes from digestion, which are alkaline. So you're losing alkaline like crazy. What is left? Acid. So you're metabolic acidosis. If you were vomiting, you're getting rid of stomach acid. So you're losing acid. What is left? Metabolic alkalosis. Okay? Remember those things. You will see that again. A multi. If an infant has not passed meconium stool in the first 24 to 36 hours, what would you assess for?
Is this a select all?
Yes.
Thank you.
You're very welcome. So electrolytes we don't talk about when you talk about no meconium. It's cystic fibrosis, hypothyroid, and Hirschsprung. Those are the big three. It's like strep with rheumatic fever and acute glomerulonephritis. Those are things you see. Deficiency of vitamin D causes. That would be with a lactose intolerance, right? Vitamin D or calcium deficiencies. And actually, that's called rickets. Scurvy is vitamin C. And the other ones are not where it causes or the name. Another multi. What treatment can the nurse anticipate to a child unable to drink or eat with profuse vomiting and diarrhea? I hit you with a couple of these questions to make sure you understand what is the treatment. What's the treatment for vomiting? What's the treatment for diarrhea? When would you not give PO? When do you give? And it's basic metabolic profile on any quote dehydration and IV fluids, unable to eat or drink. You're not going to give them more something to vomit some more. Another multi. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? Remember that cecum has burst and all of these nasty infections have been spewed into the peritoneal cavity. They've cleaned it up, they've sewed it up. What's the kid gonna have? Well, you're not gonna put them on complete bed rest. They need to be up, out of bed, ambulating, preventing all sorts of complications. NG tube to keep the stomach acid out of the intestines because it's angry. IV antibiotics for the infection, and we're going to look at the surgical site because it will dehiss. Passage of urine, usually at night, in children who should have voluntary bladder control. What is the name of it? And I'm going to give you what some of these other ones here is a time that I can. I know one was on the HESI, you might see it, but it's when you urinate at night, it's enuresis. Now, an epispadias is in a male and a hypospadias is in a male. Epispadias is not the opening on the end of the penis like it should. It's on top somewhere. And hypospadias, the opening's on the bottom. There's nothing coming out the end. These children, you cannot circumcise. They will, before they're a year old, they, under general anesthesia, splay the penis open, make a cavity, then they put in a catheter. They use the foreskin and do a plastic closure. That catheter stays in for 7 to 10 days. We do nothing with it. We keep it inside a bladder so it doesn't urinate everywhere. And these kids do well. We like to do it before potty training. Another multi. What is Hirschsprung's disease? Hmm. There's no nerves in the intestines. It causes a megacolon, constipation, and no stool, right? In the first 24 to 36 hours. Multi. When teaching parents about Hirschsprung disease, the nurse would include what? What do we know about Hirschsprung's now? It's got dead nerve tissue, which is all distended, and there's no peristalsis. Means it can't move. Sometimes you'll see that little ribbon stool, but usually no. It's a bowel obstruction, and you need to be monitoring those bowel habits to make sure it moves, especially the older infants. And it's that two-stage surgery usually. As I said, we never routinely give laxatives and enemas. And Hirschsprung's is dead bowel, no nerves, so it has to be taken out. What type of stools would an infant with Hirschsprung disease have? It's a tiny little anus opening. As I said, it looks like frosting that you push through and make, cute little designs on the cake. And it's called ribbon shaped. Very good. Which is a condition that occurs mainly in children when the intestines telescope into itself. Telling you, this is one of the most painful things to see children, and there's nothing you can do. I mean, even giving pain medicine, these kids, they're screaming, and it's called intussusception. Gastroesophageal reflux disease, GERD. What's that? And that's when the stomach contents reflux into the esophagus and it causes pain. In infants, you'll see them arch their back when they reflux, like, oh, this kid's refluxing. Very simple to see. IBS involves what? Inflammatory bowel disease. Where is it? Everywhere in the intestines. Remember, this is mouth to anus. Anywhere in there could be inflamed. What would the nurse be looking for with a patient with Meckel diverticulum? Is painless rectal bleeding. Close enough. A 6-year-old child goes to the ER due to abdominal pain, fever, vomiting for the last day. What assessment's priority? What do you need to know or see? What's the priority? They have pain, fever, and vomiting. You got to figure out what's going on with this child, right? Where's the pain? The description. Is it right lower quadrant or is it umbilicus? Makes a difference in care. What would the nurse expect to see in an infant with biliary atresia? That means no opening from the liver to the common bile duct. No No bile is being into the small intestines for digestion. What does bile do? So along with there's no color to these stools, clay colored. Remember, they're not digesting fat. So you would see that abdominal distension. What structure of the mouth can be impacted by cleft lip and palate? You know, this is such a really refined plastic surgery. They have to really make sure that the corners are so close so you don't have crooked lips. It's anywhere, hard lip, soft, all over. Cleft lip repair is typically done when? And if you think about infants, their big thing is all with their mouth. They want to suck. So we got to do it quick, right? So that they can put their lips around something. It's 2 to 3 months they do the surgery for the lip. Palate, later, 6 to 12. And that's this question. It's 6 to 12 months. Yep. Esophageal atresia. What is it? Remember, A means without. Osis is a narrowing of some sort of lumen. Those things you see many different ways. It's a lack of an opening to the esophagus, to the stomach. Atresia without an opening. What are the classic signs of esophageal atresia and tracheoesophageal fistula? No opening from the mouth to the stomach, and then a fistula between the trachea and esophagus. What does that mean? That means these kids are having constant mini aspirations. They're aspirating, they're choking, they're gagging, and they're becoming blue. They're multi. A neonate with suspected tracheoesophageal fistula, nursing care should include what? So you have a hole connecting the esophagus and the trachea. No feeding at all. NPO, or they're going to aspirate it. Elevate the head of the bed. NPO, suction at the bedside. IV fluids and antibiotics as preventative for all that aspiration that's going on. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? That's your reflux. That is, they're having many aspirations. Treatment, diet, meds, maybe a Nissan fundoplication. What is ranitidine used for a child with peptic ulcer disease? I mean, ranitidine we don't use anymore. Your book still has it. We know right now it's Pepsid from famotidine. So, and before ranitidine was simethicone. We don't use anymore either. And what it does, it reduces the amount of acid produced. So it decreases that caustic material causing ulcers. Signs and symptoms of hypertrophic pyloric stenosis. What's pyloric stenosis? This is the one with projectile vomiting, and you're going to feel right below that xiphoid process, a little bit to the right, a little marble or an olive, and you do feel it. That is the pyloric valve. Signs and symptoms of hypertrophic pyloric stenosis. And remember, 3 weeks to 3 months. These are young parents with young babies, and they are upset and they're worried. This is vomiting across the room, and they need surgery. Parents need a lot of support. Preoperative treatment of pyloric stenosis includes, once you ask about vomiting, is it dribbling or across the room, and you hear across the room, what are you going to do? Make sure they stop feeding the child. And because they're so young, you need an IV. They're going to need at least a little dextrose going. They don't tolerate more than 2 or 3 hours without fluids. What does celiac disease affect? Where is it in the body? What is celiac disease? It's a gluten problem. It's all about digestion, food. Where does that occur? And that's the answer, small intestines. Do you see how I'm thinking? Okay. If you have celiac disease, what should you eliminate from your diet? Wheat, rye, barley, and oats. And as I said, good alternative is your rice. Multi. Vitamins that children with celiac disease are prone to lose are, remember, you have these bulky, odorous stools. Why? What are they losing? And that's the vitamins that you need. I mean, we feed them high calorie, high protein diets and low fat. They're not getting fat vitamins. Vitamin C is water soluble. The rest are fat, and that's why they lose it. They're not digesting it. What foods would you select for a child with celiac disease? Remember, they can't have wheat, rye, barley, or oats. That's all your breadings. That is your cake, your cupcakes. That's your toast. That's your macaroni. That's all the good stuff, right? So give them some eggs, bananas, milk, all that good stuff. Yes. Phimosis is not covered in the chapter. This is a male who's born and they're not circumcised. And what happens is it's so tight, you can't pull it down. And this happened to Christian, my grandson. I couldn't pull it down. Now, why is that important to pull down the foreskin? Because you need to clean it every day because it gets a buildup of schmegma, which is like a petri dish, which can cause urinary tract infections. So at 1 month with a pacifier with sugar water, he had it done at the doctor's office and he did very well. What's a hydrocele? Again, I didn't cover it, but it's water, right? Hydro. Where is that water? And that's around the testes. These children older might see incontinent when they are potty trained and pain in the testicle. You'll treat it with broad spectrum antibiotic. Rosefen's a good one. What is cryptorchidism? This is something the pediatrician does to all male infants on the first visit into the doctor's office. So this is all about the testicles and are they where they should be or are they up inside the cavity? Now, remember males, when it's cold, the testicles suck up. When it's warm, they tend to hang. It's just what they do. So if you're going to examine a newborn infant for this, which is important, we want a warm place, right? And another question would be, if it's not down, let's say this is 6, 9 months down the line, have you ever felt it before? Because it doesn't like to be up in that abdominal cavity. It's too hot. It kills it. So You suspect an infant has cryptorchidism. How are you going to examine this infant? A warm room, get those balls sagging, and then you can really make sure that it's not there. Now, hypospadias. Remember, this is all about the opening of the urethra. Where is it? And this is known the anatomy and the proper names. So it's on the ventral or underneath side. Other multi. How is a hypospadias corrected? We can't have them urinating out of a hole from underneath, right? We want to stick it on the end. And what are those things that we need to know in order to do it correctly? We want to keep the foreskin. They cannot be circumcised. This could be a problem in some face, right? The Jewish likes to do brisks. You can't. And then they'll put that stent, that catheter in postoperatively. And surgery is not local. They fillet the penis open. So it is definitely general anesthesia. What is bladder exstrophy? It's like an omphalocele or a gastroschisis. They're about the same thing. Oops. It's when the bladder is born on the outside. Sorry, trying to get through this for y'all. What is the priority nursing care for an infant with bladder exstrophy? Whenever you have your insides born on the outside, what is the big thing? I mean, you always want to worry about infection, absolutely. But the other thing we worry about is the skin integrity, right? We want to make sure that the skin stays good, it doesn't die, so we can put it back in, because everything's still connected the way it should be. What are the clinical manifestations of nephrotic syndrome? Remember, nephrotic syndrome is not renal failure. The kidneys are working. They're just saying, proteins, I can't stand you, goodbye. So you're losing your albumin, low serum albumin. You're going to have proteinuria, and you're going to have all the swelling, extracellular, so generalized edema. Children with nephrotic syndromes are often given what medications for fluid overload? This is a big concept. They've lost all the protein, albumin intravascularly. Okay, it's spewing fluid extracellularly. You want to pull the fluid back in. And the way you do that is by giving albumin. It replaces it. It sucks the fluid back into the vessel. And you give some Lasix and it will push it and you urinate out the extra fluid. Big concept there. What is used to treat nephrotic syndrome in children? And it's prednisone. It is not an infection, so it's not antibiotics. We want to stop the inflammation. It's prednisone. A child's admitted with acute glomerulonephritis. What recent illness could validate this finding? What causes it many times? And it's strep. So any infection, sore throat, pharyngitis, it's the strep infection that caused it. What is the priority nursing care of a child with nephrotic syndrome? Nephrotic syndrome, they have no albumin, no protein, fluids going extracellularly. I mean, what do you need to do? How do you care for this? We are going to monitor intake, output, daily weights. Fluid balance is how we monitor the best. Daily weights, anything with fluids. Nephrotic syndrome, acute glomerulonephritis, intake, output, daily weights. Why is erythropoietin used in chronic kidney failure? What does that do? What it does is just like a normal kidney does is working. It produces erythropoietin, which makes red blood cells. So it increases the production. Another multi. Children with chronic kidney disease can have renal osteodystrophy. What can this do to the child? What does osteodystrophy mean? It means bones. Dystrophy means it's just not right, right? So what does it do? It causes skeletal abnormalities. It's not going to grow the way it could. And it also has to do with calcium levels, high parathyroid levels. A diagnostic finding of acute glomerulonephritis may be what? How do you see if the kid had a strep infection? Right? Acute glomerulonephritis, strep infection, not treated. What's the lab test that shows you all about strep? And that is the ASO titer. Look at the middles, anti-streptolysin. It does say, oh, it's elevated. Yes, it was due to a strep infection, not checked. Which complication of peritoneal dialysis is most important to avoid? Remember, in peritoneal dialysis, your abdomen, your peritoneal cavity is your kidney. You don't want it infected. So you are going to prevent peritonitis. What clinical assessment is most important to report for a child diagnosed with an acute kidney trauma? You know, I had this 9-year-old boy come into the ER playing hide and seek, rounded a corner, torn to his side, and his back hit a hitch on a trailer. Came in with a huge bruise on his back. He had a fractured kidney. That child's potassium was 7.5. You're going to see that cracking. You're going to see elevated potassiums. Multi. What should the nurse anticipate for a child who just had a renal biopsy? Remember I said renal biopsy and your cardiac cath post-op are very, very similar post-procedure. So these children, intake output, because you touch the kidney, you're going to look at the dressing to see if there's urine or blood, bed rest 24 hours. And these children, no out of bed, no ambulation. What would you do if the fluid draining from peritoneal dialysis has changed color and it's cloudy? What does that mean? Isn't it supposed to do that? No, it's not. That means something's happening. There's an infection. Notify the healthcare provider so you can get an antibiotic. And last question, what would the nurse provide to an infant that cannot eat normally? How about that child with that tracheoesophageal fistula? They can't eat. What are you going to provide to that child? It's promoting good growth and development. And that's your good old pacifier. You are not going to put anything in their mouth, no liquids in their mouth. You're not going to do any vigorous anything. You want to give them that stress reliever, that pacifier. Let's see how we did. Number 3, Sierra. Good job, Sierra. Sorry about my squeaky voice. We had a W. Good job, W. Number 1, Alicia. Good job, Alicia. Mac, you're 4, and we have SB. So remember, next week we'll start our reviews. Good thing about next week, there's no quiz. Can you imagine? Now remember, I want you to submit your stuff as soon as you get it, and I can help you. All right, I'll see it, I'll correct it, I'll send it back to you. So thanks for putting up with my squeaky voice. I hope that you could understand it, and I'll be sending you my recording as soon as I have it. You all have a great night.
Thank you.
Take care,
Uh,
guys.
Professor, can I ask you what project like I can do right
Absolutely.
now?
Absolutely.